morning, everybody. Welcome to Pediatric Grand Rounds. This is kind of a special day. We don't really appreciate all the good things that have happened during this weird time of doing virtual things. But this is an example of a good one because we've had a request out for speakers from all over the country who can come and do virtual presentations when otherwise that might not be an option. And this is an example of one that was suggested to me by Dr. Michelle Terry, and we're really, really excited to have her today. So today presenting is Dr. Megan Sandel, who is the co-lead PI with Children's Health Watch, the co-director of the Grow Clinic at Boston Medical Center, and an associate professor of pediatrics at the Boston University Schools of Medicine and Public Health. She's the former pediatric medical director of Boston Healthcare for the Homeless program, and she's a nationally recognized expert on housing and child health. In 1998, she published with other doctors at Boston Medical Center the Doc for Kids report, which is a national report on how housing affects child health and the first of its kind. Over the course of her career, she has written numerous peer-reviewed scientific articles and papers on this subject. In addition to lots of other things, she has served as the medical director of the National Center for Medical Legal Partnership. So we're really, really excited to have you speaking for us today on this really important topic. And welcome, Dr. Sandel.
Thank you so much. I am so honored to be asked. I think Seattle Children's is such a beacon for a lot of amazing work, and I especially am honored to be asked by Dr. Michelle Terry, who is a hero of mine. There are many amazing doctors you have. I think Dr. Esther Chung is now there, Dr. Lee Chang. This is just an incredible honor. So I will say this is probably the first time I'm going to say the title that I submitted 3 months ago when I was asked is not the title I actually want to use anymore. So this may be the first time a Grand Round speaker changes her title. But stable, affordable housing is a prescription for good health, I think doesn't work for me anymore. So the title that I'm going to replace it with is A Place to Call Home, How Equitable Housing Improves Child and Family Health. And I'm going to do a shameless plug of a podcast that I did with for the SIREN Network, the Social Intervention Research Evaluation Network. I did a conversation with Dr. Rhea Boyd, and it is a conversation that I have come back to and re-listened to, and it made me understand in deeper depths why we shouldn't be using medical language to talk about social context. And so I have retired that title and now really want to focus on equitable housing. And I'm going to actually push us by the end, hopefully, to go deeper to maybe equity isn't enough and we need to be about tearing down barriers. So I'm going to shamelessly plug the podcast if you have 30 minutes. So the roadmap of my talk, I'm going to hopefully talk for about 45 minutes and then open it up for questions. So please start to put questions in the chat. I'm going to try and help you give a dimensional framework for how homes affect health. And I think over my career, this has evolved for me from quality, and my first research was in housing and asthma and how quality affected health, to more stability, affordability, working with both Boston Healthcare for the Homeless and then also working now with Children's Health Watch around how toxic being behind on rent is. And then most recently in the last 5 years, I've been focused a lot on location, neighborhood level effects. And I want to just, as we think about multiple levels of how housing and health are affected, I want us to understand place and how much place concentrates inequity. So as we think about individual level factors, system level factors, structural level factors, I put place between system and structure as something that we need to understand deeply around how location is a place of inequity. And we need to be doing place-based strategies, not just person-based strategies any longer. I'll then talk about different levels of interaction, how we can do this in clinical practice, both from like the screening level, the system alignment level, the policy level, and think about those as interchanging cogs and wheels of effective action. And then lastly, I'll talk about this kind of operational health equity and how we need to move beyond just equitable treatment to true equity. I've started to want to ground my talks in kind of how I think sometimes we've now broken the term social determinants. And that I think it's really important as we think about housing and where you live as a social factor. I think it's really important that we just have some grounding conversations about what that means. So I think the first thing that's really important that I feel like I need to name is that social driving is as much about assets as it is about deficits. I think we spend a lot of time talking about, oh, that patient has social determinants of health, and we think of that as a negative term. When I'll say my children have spectacular social determinants of health, right? They have two parents that are doctors. They live in a great neighborhood next to a park. They live with great schools. And so it's really important that we talk about social factors and how they drive outcomes as both asset and deficit, not just deficits. I think the second piece is that they're often multifactorial. And I think in our effort to sometimes address them, we end up delineating them, right? We're doing a food intervention, or we're doing a housing intervention, or we're doing an educational intervention. And that's not how people live, right? People are always juggling different bills and thinking about different things. And so I think we do a disservice when we isolate them. We need to think about them in multifactorial ways because that's how people live. And then I think the last thing is we have to name that social factors don't happen by accident. These are structural racism and oppression in action. And so when we name social factor differences, if we do not name the structural factors that resulted in the differences that we're seeing, I think we're doing a real disservice. And I think housing is maybe one of the most powerful ways in which social factors drive health outcomes in a non-accidental way. So one of the nice frameworks is that I think it's really great to think about the housing and health research in these 4 domains. And I like to lift up Dr. Lauren Taylor's Health Affairs article in 2018 as just a really nice grounding article around ways in which stability, quality and safety, affordability, and neighborhood location impact health. And so if you're looking for kind of a, particularly trainees, kind of a grounding article, I would start there. As we think about, the evidence of home quality and health, I think it's really important for us to name all the ways that home quality matter. I like to name accidents actually as a really important factor, because once you take motor vehicle accidents away, the leading cause of death for kids are home related. They're fires, drownings, falls, other things. And so it's really important for us to name accidents and unintentional injuries as being home related, and to an extent intentional injuries being location related. So I think accidents and home quality need to be connected. I started my initial career in housing with asthma, right? I admitted a kid to the ICU with asthma as an intern in what's now known as the Boston Combined Residency. And I ended up asking a fateful question of the family of what had changed, right? The kid had previously well-controlled asthma and now was in the ICU. And the family talked about getting a cat. And if we were in person, I would ask you, why'd they get the cat? And you would tell me, you would say, because of mice. And it's true, they had found mouse droppings in the kid's bed. They were really upset. They couldn't get the landlord to make a difference. And so they got a cat, and the child was allergic to cats, and the child ended up in the ICU. And for me as a trainee, it was like that eureka moment where I was like, oh my goodness, the thing I want to write for is a healthy home, and that's not stocked at our pharmacy. So what are the ways in which we can make almost a housing prescription to try and think about things? I'll lift up that we know a lot about housing quality, whether it be pests, cockroaches, and mice. We know a lot about mold and dampness. Smoke-free housing is really important. 86% of the time if kids are exposed to tobacco smoke, it's in their home. We're understanding lower and lower levels of lead exposure and the developmental delays, whether it be from lead in housing, in paint, or water, or soil. And I think many of the amazing healthy housing research comes out of King County, Dr. Jim Krieger and colleagues. And then I always like to isolate and talk about energy, right? Heat or eat, or cool or eat, because that's really important. Where I don't think we spend enough time is home quality, not just with physical health, but with mental health. And so I like to lift up this study that is featured on a really great website called howhousingmatters.org. It is funded by the MacArthur Foundation. The Urban Institute actually curates it right now. And so if you're looking for anything lit review wise around how housing matters, go to howhousingmatters.org. And this study was done in 3 cities. Rebecca Levine Coley is the first author, and it showed that actually poor housing quality was the strongest behavior of emotional and behavioral problems of low-income children at their school. So they had carried over the quality housing issues to a different environment. And the feeling of the authors is that a lot of the association traveled through children's well-being through parental stress, and how those parenting behaviors created mental health challenges that then carried over. And so I always like to talk about housing is not just about physical health, it's about mental health. It's not just about kids, it's about their parents. And so we have to start to broaden our definitions. And I'll share some research in a couple of minutes around how a housing intervention impacted not just the kids, but the parents also in terms of measuring impact. So as we think about quality, I like to talk about stability, and I like to talk about it in terms of an iceberg. We talk a lot about homelessness, and we should, but homelessness is part of the iceberg you can see. There's a lot of iceberg below the surface. So there's the hidden homeless, the people who are housing insecure. There are people who have multiple moves or overcrowded, doubled up. And often the root cause of that is unaffordable housing. And so I'm going to share with you some research from our Children's Health Watch research network. For those that aren't familiar, Children's Health Watch was founded over 20 years ago, and is the national kind of office is based out of Boston Medical Center, but we actually collect data in 5 cities, in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And we interview families in either pediatric emergency departments or primary care settings of families with young children, children 0 to 4 years of age. And so what this was that in the late 2000, around 2009, we started adding more housing questions to our interview. And so over about a 5-year period, we interviewed over 22,000 renter families with a child 0 to 4. And we found 3 forms of housing instability. So 34% of the time, 1/3 of the time, a renter family had a form of housing instability. Either they were reporting being behind on rent in the past year, they had multiple moves, which we defined as how many places had the child lived, and they answered 3 or more. That meant they had moved twice. And we asked about whether or not the family was currently homeless or had a history of homelessness in the child's young life. And what we found was each of those 3 were actually associated with adverse health. I will note in 2011 in the American Journal of Public Health, we actually published on overcrowding, and we did not see overcrowding as being associated with adverse health. It was associated with food insecurity, but not adverse health. And so in this case, we defined this 3 things: behind on rent, multiple moves, and history of homelessness, but not overcrowding as our 3 forms. And we published this in Pediatrics in 2018. I'm the first author if you want to try and find it. So really common, right? 1 out of 3 families had it. The second is that there wasn't a lot of overlap between the groups, which is really interesting, right? The behind on rent group was kind of distinct from the homeless in the child's lifetime group, was kind of distinct from the multiple moves group. And so 86% of the time, if you were positive for one form, you were only positive for one form. And so as we think about it, these are 3 distinct kind of groups. And we just published an article in American Journal of Preventative Medicine about screening questions, because what we found is our Children's Health Watch screening questions and the ones that are recommended by the Centers for Medicaid and Medicare actually identify different groups of people. So it's really important. The questions matter in terms of what you're moving forward. And then the third kind of take home that I want you to walk away from is we stacked up the adjusted odds ratios of both the child outcomes and the caregiver outcomes and some of the health outcomes. And what we saw was really striking, right? In this case, the stable housing group, the group that doesn't have behind on rent, multiple moves, or homelessness, is the red bar. And then the purple bar is the behind on rent group. The green bar is the multiple moves group, and the blue bar is the homeless group. And so, right, we knew that homelessness was bad for your health, right? 50% increased risk of child fair poor health, 100% mothers reporting fair poor health, 200% increase in maternal depression, 4-fold increase in food insecurity and healthcare cost trade-offs. But look at that behind on rent bar. The behind on rent group was just as bad as the homeless group in terms of adjusted odds ratios. And so when we talk about ending homelessness, that's great. But we also need to end behind on rent if we're going to have our ultimate health impact. I think as we talk about it, quality, stability, affordability. Now I want to talk a little bit about location. And this is a map of the city of New York. And what you see here is the overlap between neighborhoods that had concentrated poverty, right? Had more than 30% of the people living in that neighborhood below the federal poverty limit. And again, if we were in person, I would ask you all, define the level of federal poverty right now for a family of four. And many of you may know it, but for those that don't, it's about $24,000. So you could imagine 30% of the people living in a neighborhood living in the city of New York on $24,000 a year for a family of four, and what that neighborhood looks like, what the different kind of concentrated poverty effects. And so what this shows is the overlap between what was the concentrated poverty rate in 1995 and what's the concentrated poverty rate 10 to 15 years later. And what you see is a lot of overlap. The black dots and that dark red are almost exactly identical. And so think about that, a generation of kids growing up with concentrated poverty. And so it gives you this sense of kind of your zip code maybe as tied to your poverty level and how that plays out. And one other way to think about it is not just concentrated poverty, but actually looking at neighborhood segregation and opportunity. And for those that aren't familiar, I really love the diversitydatakids.org website. I really encourage people to look at it. It just recently got updated. It's Dolores Acevedo Garcia and her team at Brandeis. And so what you can do is child opportunity maps. And again, as we talk about, this isn't by accident. This is an index that takes 17 different factors developed by the Kirwan Institute at Ohio State. And what they do is they basically take things like educational opportunities, health and physical environment, neighborhood and social economic opportunity, and then they take those 17 factors and then they create a 5-tiered system of very high opportunity neighborhoods with the dark red to the very low opportunity that is the light yellow, right? And so this is the Atlanta metro area. So you all in Seattle could pull up your opportunity maps. You may have already mapped them. But I think as we look at this opportunity map, now we need to start talking about where do the non-Hispanic white kids live and where do the non-Hispanic Black kids live. And so as we see here, the dots are the concentration of white kids that are disproportionately in the higher opportunity neighborhoods. And then we show where the non-Hispanic Black kids live, and they're disproportionately in the lower opportunity neighborhoods. And so as we think about that, again, this is where place concentrates inequity, is by having lower opportunities for things like education, for things like economic opportunity. And so as we think about this, this is a map that one of my colleagues helped generate, Dr. Renee Boynton Jarrett, who founded the Vital Village Network at Boston Medical Center. And in this case, we worked with her colleagues to actually create an opportunity map. And then we pulled out of the medical records the blood pressure readings of 3-year-olds. And I think you all know, right, that's when we start regularly pulling blood pressures and measuring them. And so we looked at the prevalence of an elevated blood pressure, right, above the 95th percentile for age. And what you can see is you have these higher content, higher circles, higher prevalence in the lower opportunity neighborhoods. And what's really interesting is you'll see the highest ones on the border neighborhoods, right? Where you have one side that is the high opportunity and then the low opportunity side by side. And so I think that where we start to think about where does social end and where does biology begin, this is where you're seeing a biologic association. Now, this is an ecologic study. We published this in Academic Pediatrics in 2016 in their child poverty special supplement, because we wanted to emphasize that neighborhood level interventions are as important as individual level interventions to lifting kids out of poverty. So with that, I'm going to move to talking about COVID. So as we think about place and how deep-rooted inequities ended up resulting in really disproportionate maps in every city of where COVID deaths were and COVID infections. This is the city of Boston, and what you can see is where the maps are, where people paid more for rent, where there's a higher unemployment rate, were the same places where we had higher infection rates. And so again, I think as more and more my work has tried to think about how do we do things not just on the person level or the systems level, but we have to be operationalizing on the place level because of that, where the structural inequities are. So I want to shift gears a little bit about then how do we kind of promote health equity through action? And I think health systems are very interesting actors in this space, right? How do we start to think about research and screening? How do we start thinking about systems and connections? How do we start thinking about policy action and how those fit together as kind of cogs, important cogs in the wheel of how we start to use all the tools at our disposal in order to make kids healthier? So one way is through social screening. And I think pediatrics has kind of led, honestly, in this space for all of healthcare, is thinking about ways in which to do social screening. I need to give a particular shout out to Dr. Arvind Garg, who was at Boston Medical Center for many years. He just left to join UMass Memorial in Worcester, but his research on WeCare, on doing randomized controlled trials on how to do social screening and how that connects to resources is really seminal, and I think needs to be shouted out. We at Boston Medical Center built off of that research of WeCare to do a hospital-wide screening system called Thrive, where what we do is we offer to anyone who's coming in to our ambulatory practices, general internal medicine, family practice, OBGYN, pediatrics, infectious disease, and others, that we do a Thrive screening tool that it then gets documented in our electronic record, and then we automatically connect to resources as ways in which to improve outcomes. And so for us, this has been really important, not just to be able to use it as a mechanism for screening, but also for data collection to think about ways in which we need to act upstream. So again, I think if we just talk about social screening in the individual and don't talk about the system change and the policy change that needs to be done, I think we're doing ourselves a disservice as a healthcare system. Our social screening tool focuses on 10 questions in 8 areas. We do housing questions. We do the food insecurity screening. We use the hunger vital sign that Children's Health Watch helped validate. We do things around affording medications, affording utilities, caring for someone who is in need of special care, whether it be a child or an elder. We talk about transportation. And then it's interesting, we added 2 questions around employment and education, whether people were unemployed looking for a job and or interested in education. And then you'll look at the bottom, we think it's really important to be patient-centered, where we ask about these resource needs, these health-related social needs, and then we ask whether you want help with it. We don't assume whether or not somebody want help with it. And what's interesting is the top 2 places where people want our help is with unemployment and education. So this is really important as we think about ways in which we can be an anchor institution, and I'll hit on this a little bit more later. I think being able to start to think about hiring pathways and educational pathways as being part of our way to make people healthier, I think becomes really important. I will give a shout out to the kind of people who have led a lot of the Thrive development, Dr. Thea James, Stephanie Losi, and Dr. Pablo Butron de la Vega. One of the cool things about our Thrive screening tool is that when it is uploaded into the electronic record, into the Epic flow sheet, it also automatically generates an ICD-10 code. And so we're able to now see through our data tracking system who's housing unstable and homeless, who's food insecure, and other things. And that's helping us start to think through some of our rapid responses. I think as we think about the screening tools, then it becomes about systems connecting. And so one of the things that we've tried to lean in on is ways in which we can respond real time. So we've had for almost 20 years an on-site food pantry, the first hospital in the country to have an on-site food pharmacy, and we continue to try and help seed other programs. And so when people say they don't have enough food is an emergency. Do you need food tonight? We can rapidly get someone a food pantry. And we actually started a food delivery service during COVID. But we also have started to do co-location of services. So Metro Housing Boston is the regional housing network that does housing search, helps access to the back rent policies that are now in place with COVID. And then we have our Medical Legal Partnership Boston. I think you know that Boston Medical Center was the first site of Medical Legal Partnership, and MLPB is our first site. And as we think about it, this is ways in which, as you identify a housing problem, you have someone who is co-located with your navigators, co-navigating the system. And just of note, we were able to do system efficiency. So for most people, if they just called Metro Housing Boston and did the application online, typically it got about 45 days for them to get their back rent paid. Because we had the co-location site at Boston Medical Center with a housing navigator working side by side with the Metro Housing Boston, we were actually able to get people their back rent paid in 21 days. So there are ways in which you can do system efficiencies to address social factors and make it easier for people. The last thing is this idea of the highest dose. So I kind of think about like tiers of responsibility, right? You answer the social Thrive screening tool, we get you resource and listing of names. That's the low dose approach. Then if you have a medium dose approach, you have somebody who's on site who is able to do a co-location and able to do some one-stop shopping, get the application, and that's like a medium dose approach. The high dose approach is that we actually start to try and get you preference for housing. We actually do a housing prescriptions as healthcare pilot, and through some work funded by the Boston Foundation, Boston Medical Center Children's Health Watch was able to work with our health plan. We own a Medicaid managed care plan called Boston Medical Center Health Net, and then able to work with Boston Housing Authority, Medical Legal Partnership, a local community development corporation specializing in financial coaching, Nuestra Comunidad, and then a housing case management services agency called Project Hope. And we were able to build out an approach where we could identify families that were medically complex as they were utilizing more healthcare and actually start to test what did getting housing mean for them. We actually published this in Health Affairs last year on our pilot randomized controlled trial testing this approach. We identified families with a child under age 11 who was eligible for Medicaid. They were getting primary care at Boston Medical Center. Our definition of medical complexity was applied to the whole family. So it was either a child or an adult that had 3 ED visits in the past year, or the child had medical conditions requiring 2 or more specialists to get to complexity. We defined people that were housing unstable, either as having homelessness in the past year, being behind on rent, moving 2 or more times, or paying more than 50% of their family income on housing costs. And then we did an intervention assessment at baseline and every 6 months for 2 years. And what we ended up doing was a randomized controlled trial where we identified people, randomized them to a control group, which I realize in some ways it feels unethical, right? You're withholding housing for people. But our IRB was pretty clear that the usual care right now is here's an annotated resource list, call as many places as you can. And that most people do understand what a lottery is. They understand that it is, we were giving people essentially a 50% chance at getting a preference for a Boston Housing Authority unit. And so this was our way of kind of testing what did this mean. And so you were either randomized to the control group and with standard of care, the curated research list and hospital-based navigation and social work services, or you were randomized to the housing prescription group, which got you the case management at Project Hope. It got you some problem solving education. It got you financial coaching at Nuestra Comunidad, access to medical legal partnership, and priority preferred access at some public housing units. And so what's interesting is that even after just 6 months of enrollment, we started seeing differences between groups. And so I'll just give a shout out. We saw a 32% fewer kids being rated in fair or poor health from the intervention group compared to the comparison group. And we saw statistically significant lower scores on the generalized anxiety score scale and the PHQ-2 depression scale. And so it starts to give you a sense, again, that the housing intervention is benefiting not just kids, but their parents. And it's not just physical health, it's mental health improvements. So just speaking a little bit more about medical legal partnership, I think I like to describe it as an approach. And you guys have an amazing medical legal partnership at Seattle Children's, one of the the best award-winning programs. But I always want people to understand it as more than just access to legal services. This is really about identifying needs, being able to treat patients, being able to transform clinical practice, and ultimately improve health on a population level and a policy level. And so I think it's really important for us to think about those individual interactions then become pathways to those structural policy levels. And so I'm going to give you some examples from Cincinnati Children's that I think are really instructive. So this was a letter that was brought to the Cincinnati Children's primary care office, where the patient got this letter from their landlord saying, at this time, all residents are not permitted to install air conditioning units for your apartment. Anyone with an air conditioning units will be evicted immediately. And so what the family did is they brought it to their doctor and they're like, okay, my kid has asthma. You tell me to use the air conditioner. What am I supposed to do? I'm at risk of being evicted. And they have a medical legal partnership there called the HELP program, the Health and Law program. So they're like, listen, go talk to the child help lawyer who's down the hallway. Let's figure out what's happening. And what's really striking is that they went down, and then a day later, another family brought in a similar letter and got referred to the lawyer. So the lawyer was like, I'm seeing a couple of these letters. What's going on? And so what they ended up doing was actually mapping their child help cases. And they started looking at, oh, gee, these cases are pretty much overlapping with this firm that is the landlord, the common landlord for these buildings across certain neighborhoods in Cincinnati. And so what they ended up doing was actually really amazing. They used individual cases to look for a community level pattern. And they were actually, if you can believe it, able to force the sale of this firm to a better public or affordable housing developer called the Community Builders. This is featured in a pediatrics article. I want to give a shout out to Andy Beck, the first author who's generously shared his slides and let me present them. But it's about identifying and treating a substandard housing cluster using a medical legal partnership, right? You took an individual case, you looked for a pattern, you forced a systemic solution, which was making literally the landlord change. So they actually forced the sale to a better landlord. And then what you can see there is they're actually fixing the roof. They're actually making it proactive, getting rid of the mold in the building because they got a better approach. And so what's interesting is that that's one pathway, right? Individual level up to community level. What does it look like the other way? And so in Cincinnati, what they ended up doing was they looked at different neighborhood level patterns of asthma admissions. And Cincinnati Children's is kind of unique. They basically get 90+% of all the asthma admissions. And what they saw over a 2-year period was that certain neighborhoods had incredibly high rates, right? Of, 200, the highest quintile 5 had 299 admissions and only 17,000 kids. Whereas the lowest quintile 1 had like 18 admissions and 29,000 kids. So they were like, what's going on in these neighborhoods? And they picked one of the top 5 neighborhoods called the Avondale neighborhood. And so what they did is they started to map, like, where are the schools? You can see there are a lot of schools in the neighborhood. Where are the pharmacies? There aren't a lot of pharmacies. And then they did something really cool. They did a heat map of building code violations. And they ended up showing that there were pretty significant hot areas where there were a lot of building code violations. And this was featured in an article in Health Affairs. Again, Andrew Beck is the first author in 2014. And then what they did is they ended up doing this really interesting thing where they looked at the cohort of kids who had come to the emergency department, and then they looked at the heat map. And what they ended up showing was that the community level factor of the heat map actually predicted to whether or not a kid came back to the ED with an asthma exacerbation, right? And so they took a community level factor and then brought it to an individual level factor. And so this is where I think, as we think about individual data and community level data, they're related, they're interconnected. We need to think about them bi-directionally. And what's really cool is in 2019, they actually published a neighborhood level way in which they reduced the bed days in that Avondale neighborhood compared to a similar neighborhood by doing neighborhood level interventions like meds in hand, releasing after kids came into the hospital with asthma, and other neighborhood level interventions around code violations that I think made a huge difference. So place-based approaches has been something that we at Boston Medical Center have wanted to do. We committed in 2017 $6.5 million to affordable housing partnerships because we felt like affordable housing was the most determined need in our community. And we had an obligation to do a community health improvement because we were redoing our campus. And we said, we're going to put all of the money into affordable housing partnerships. And for us, I want to be clear, we were not becoming a landlord. We were not building our own housing. We were doing partnerships with key different housing agencies to try and test ways in which we could really improve housing stability and ultimately reduce healthcare costs. And so we did project related investments with Nuestra Comunidad. We actually started financing a grocery store in the first floor of one of their developments. We helped Codman Square with a building that got out of foreclosure do needed renovations to get the building up to code. We did on-site service collaborations where we did community health workers, where instead of them reporting to Boston Medical Center, they reported on-site to a Madison Park development in order to do better on-site services. We partnered with Boston Healthcare for the Homeless, Pine Street Inn, and Boston Housing Authority on supportive housing pilots to help medically complex people access housing. One of the coolest things we did is something called the Innovative Stable Housing Initiative, which was a participatory grant making project where we took $1 million and worked with Health Resources in Action, Cheers, and others. And Boston Children's matched our $1 million, and Brigham and Women's actually brought $750,000. So we actually pooled close to $3 million into action. And then we actually invested in an equity fund. And I joke that I used to think it was an equity fund to get equity, but no, it's a financial equity fund. It's something that is used as a way to build affordable housing. And so we're thinking more and more about both affordable housing development and small business development as ways in which to do place-based investing. And so I think the last piece as we think about kind of the levels of change, right? Individual level screening, systems, partnerships, testing different ways to co-locate, thinking about place-based work. I think the biggest cog in the wheel is always policy. And so I'm going to give a shout out to a really amazing multi-sector coalition called Opportunity Starts at Home. You can check out the website, www.opportunityhome.org. And what we're really trying to do is really change the conversation where housing is not just about a place to call home. It's also about your health outcomes, your educational outcomes, your economic justice outcomes. And so we're standing behind many of the new bills and infrastructure in order to make sure that we get additional housing resources so that we can actually end homelessness and actually end housing instability in our lifetime. So I have 3 more slides. Please get your questions lined up. But I think as we start to think about what does real change look like, I encourage us, this is the proverbial stream, right? Where we oftentimes will be doing downstream type of interventions. We're spending our time at disease and injury. We are doing, important clinical work. And I want to really emphasize, I sometimes get asked about like, well, but I'm a doctor and do you want me to stop doing clinical medicine? No, we have to do this work. This is what we went to our training to do. And this is what's important is that we cannot stop doing the downstream work. We need to continue to do important clinical interventions. What I'm asking is the and, right? So we're going to do this work helping people downstream, and we're going to try and start to work upstream to actually do geographic population health interventions to operationalize ways to address the social determinants of health at higher levels, the upstream work that I think we can do. And I think health systems can do this. They can do the person-based work and the place-based work to try and do it. And I think you're seeing this more and more with the Healthcare Anchor Network and other types of things. Seattle Children's is a member of the Healthcare Anchor Network. And what are ways in which we do place-based investing, place-based procurement, place-based hiring as ways in order to address economic inequities. And so as we think about it, I think the cartoons of kind of equality is not equity. I have to admit, I used to use this cartoon. And the reason is I really wanted to make sure people understood that equity was not equality, right? As we think about kind of people being different heights and you treat them all the same, right? You give them all one box to stand on. And really only the tallest person gets to that apple of opportunity in the tree, right? The medium height person and the shorter person, they get closer, but they're not getting there. It's only when you treat them equitably that they all get that same fair shot, right? The tall person gets one box, gets the apple of opportunity. The medium height person gets two boxes, and the short person gets three boxes. And so the tension with equity is twofold. One is that in order to treat people equitably, you have to treat them unequally. You have to give some people more. And to an extent, you have to also acknowledge that people didn't get to different heights by accident, that it is structural racism and oppression that start people in different places. But one of the things that I'm realizing is that equity is not enough, right? And so as we talk about this, right, equality is assumption that all will benefit, and the starting point is the same, and therefore we are going to give everyone the same treatment, and we know that's not enough, right? We know that we need to get to equitable treatment, but fundamentally equitable treatment is sometimes about filling gaps, not eliminating gaps, and that it is important, and sometimes we do need to start there to do it, but that equity, true equity, is about tearing down that wall. And can we imagine a world without those walls? Because in a world of scarcity, that's why we build walls. That's why we make you fill out an 11-page application for SNAP and then essentially provide essentially the same information to get your Medicaid benefit, and then essentially apply the same benefit for getting your child care voucher, and then essentially provide the same information in order to get your unemployment check. And we design those systems with those walls because we think that we need those walls. And I'm going to challenge us that more and more, as we think about what does equity look like, it is not the middle cartoon. It's actually the far right cartoon. And I think that this is where we have to be operationalizing as health systems, not just to do the best person-based care, but to tackle those zip codes. There's no reason why certain zip codes in Seattle need to have different outcomes. It's functionally about the walls that have been built. And so I think I'm really excited to talk more with you. I'm happy to take down the slide, or I'm happy to keep it up and answer your questions. So thank you so much.
Thank you. While I let people continue to write their comments and questions in the chat, can you just remind us the name of your podcast? We also know Dr. Boyd. She's given a couple of grand rounds for us in the past year, so we're fans of hers now, in addition to you. So can you just plug your podcast one more time? And then Emily, maybe we could send it out to the group with the evaluations too. I'll put it in the chat.
Yeah, that would be awesome. It's the Siren Network, and they call it Coffee and Science is the podcast. And
Coffee and Science.
Coffee and Science.
Love
and
it.
It happens every 2 weeks on a Friday, and it's live, and then they edit it and then post it. So I downloaded it on Spotify, but I think it's on most of the, if you whatever, search for Siren Coffee and Science, you should be able to find it. And if you can't, let me know, and I'm happy to send it.
Thank you.
So I'm shamelessly plugging my podcast, so thank you for that.
Everyone needs a podcast now these days.
I was just about to say, yeah, I'm showing my age, right? Where I was like, "Ooh, a podcast," but yeah, I figured it out. I downloaded it, and it was great. So, and it's a nice series. I encourage it. It's based on the National Academy of Science did a report around asking and referring and thinking about different ways you kind of assess and refer for social determinants of health. And in my typical fashion, I kind of blew it up, and I was like, yeah, I don't want to talk about assisting and referring. I want to talk about structural change. And so, and Dr. Rhea Boyd was the best person to talk to about it. So.
Great choice. Fabulous. So everyone should check that out. And we have a comment and a question from Dr. Esther Chung, who I think knows you, who you know. Thank you for an inspiring and impactful Grand Rounds, Megan. Your tireless efforts have helped so many families. Many people are uncomfortable talking about their housing instability. How can we help/advocate at the individual and community levels to overcome stigma associated with unstable housing?
Yeah, no, thank you, Esther, so much. And I think right back at you, you have been an inspiration. I think there are two things. One is I will say that oftentimes people are very uncomfortable asking questions about things they cannot solve for right away. And so it's part of why I think many health systems like to start with, say, food insecurity screening. It feels very doable, and therefore they can move forward. I will just encourage that one of the reasons why our hospital has leaned in so hard to housing and investing in housing is because we started asking the questions, and we were uncovering that, especially among our most expensive patients, that half of them were housing unstable and homeless. And it really started becoming like we aren't just doing this because it's good charity work. We're doing this because like this is part of our business model, is actually thinking about how to solve this to make people healthier. And so I do really encourage thinking about ways to screen as a way to just understand the scope of the problem among your patient population and how that fits with your kind of local ecosystem. So I think that's important. The other piece is I do think we don't have the same level of validated screening tools that we do in the food insecurity world, but I do think using simple tools, we use literally it's asking how many places has the child lived in the past year. In the past year, have you been behind on your rent or mortgage? Both of, and then asking about, do you have a steady place to sleep at night is the homeless screening question. Some people will say, are you currently staying or have stayed in a shelter recently? But I think, as in any social screening, I think explaining why you're asking the question is really essential. And then I think it's really important to, do local focus groups, human-centered design. What's the best way to ask the question? What's the best context? There's a lot of really interesting research around, should you do it anonymously on an iPad? Is that better than having somebody ask directly? But I do think understanding family social context is important to providing good care. And I think most families, if you explain to them why you're asking and where the information is and how it's being used and other things. And then most importantly, if you do screen for a health related social need, not assuming they want help from you for it. It's more of saying like, would you like some help with it? This is the type of thing that we sometimes can do. And then making sure you manage their expectations around it. I will say that not everyone believes in universal social screening because of the fear of it raising people's expectations of things that can be done. But I do think it's important for us to understand social context so that we can understand all the levels that we need to operationalize it.
Thank you so much. I'll wait to see if anyone else is typing. And also, to our audience, if you feel brave enough, you can unmute yourself and ask your question out loud.
See, I was so nervous. I like flew through my slides. Yeah.
You did great.
Oh,
It's
thanks.
actually nice to have some time at the end either way. So we appreciate you. And I appreciate your talk title change too.
Yeah, I think it's an interesting dynamic around, it was intentional to use medical terminology as a hook, right? As a communication tool. But I do think words really matter. And so I have, yes, you will, it's hard for me to break my housing prescription, or housing as a vaccine is something that I've also said in the past. And so I'm gonna break the habit. You're my first grand rounds of trying to break the habit.
It's a really interesting concept because I agree. I would have used that same hook and I still think of it that way. So
Yeah.
trying to uncouple it is, I'm going to work on that too.
Yeah.
All right. I'll give a few more minutes of silence. Oh, Dr. Otero Flowers, what advice would you give for someone just getting started in this work in terms of joining or starting a legal or community partnership?
Yeah, no, it's a great question. I think that in this case, I'm a big fan of intraprofessional or interprofessional collaboration. So I sometimes think I learned a lot about being a doctor from lawyers. Training early on with legal aid attorneys was really transformational for me in the sense of, if you think about how we as doctors are trained, particularly, oftentimes it's very hierarchical, right? Like the intern talks to the resident, talks to the fellow, talks to the attending, And there's a team concept, which is good, but it is pretty much like ultimately the ultimate decider is kind of the head of the team. Lawyers are trained very differently. They're trained very individually, and they're trained, if you don't like the answer you get, you go up the food chain. Like you appeal it, you go up. Like and so for doctors, it's kind of like, oh wait, like you can buck the chain, like you can appeal. And so I do think that being able to find your local legal aid and or law school becomes a really important. A lot of lawyers are more like residents than they are like medical students. When they're training, they often will do legal aid clinics. And so a lot of the medical legal partnerships will start with either a legal aid office or a law school clinic as the legal partner, and then finding a community health center or others. I will give a shout out the National Center for Medical Legal Partnership, which is now based at George Washington University, has been doing a lot of work with the National Association of Community Health Centers and actually Kaiser. And Kaiser has been funding a lot of expansion in using particularly medical legal partnerships to address housing quality. And so definitely want to give a shout out to that network, the Health Begins network. And so don't start from scratch. Go to the experts, go to the National Center, to Health Begins, to the Kaiser network to try and get some of their technical assistance and toolkits. And then I do think that the best housing people in your backyard are going to be your public housing authority. And you have a great one in King County. And so I would definitely encourage going to the public housing resources, because they are the ones with the housing, and they often want to partner with healthcare because we have the services. So it's a beautiful marriage of the housing and the services to be most effective.
Thank you. And that sounds like a good future potential Grand Rounds topic too. If we have anyone local or any connections, send them to me as well.
Definitely.
All right. Well, I'll start wrapping up just in case someone's typing. I just want to say thank you so much, Dr. Sandel. We really appreciate your expertise, and this topic is really, really important. I was also just about to thank Dr. Terry, and she sent us a message. Thank you, Megan. To your point about words matter, the AAP just launched a policy campaign named just that, with guidance on inclusive, anti biased, anti racist language. So I encourage everyone to check that out as well. And again, I'll just say thank you so much to everyone for being here. Thank you, Dr. Sandel, for being here. And to anyone who's tuning in and listening, thanks for sticking with us during this virtual time. And if you have suggestions for speakers like Dr. Sandel, please send them my way. Thanks again, everybody. Have a great Thursday. And we'll see you in person next time.
Yeah. Awesome.
Thanks.
Bye, guys.
Bye, everyone. Thank you.